Assalamu alaikum. I hope you're all doing fine. I am Dr. Muhammad Ali Rabbani, and today we are going to discuss the gross anatomy of breast. As you may notice, I am currently recording it as a part of the lecture series on gross anatomy of upper limb. This particular topic is taught both in upper limb and lower limb because of its particular position, as it is present above the pectoral region, and it shares a lot of arterial and venous drainages and lymphatics and nerves with the upper limb. That's why it is connected to the upper limb, and due to its present above the rib cage and on the medial aspect, its connections of the vessels and nerves and lymphatics with those of thorax, it is considered a part of thorax too. So don't have to worry about it. We will cover it in entirety, and when you are reading it from your books, you may find it in either one of the two chapters. That will be upper limb, as it's present in Snell's anatomy and BD Churacea, and it may be present in thorax region as present in Keith Moore's clinically oriented anatomy. So let's start with our topic. Inshallah, by the end of this session, we shall be able to describe the structures and divisions of breast tissue, its location. We will elaborate its blood supply, venous drainage, lymphatics, and various clinical conditions. So, breast tissue or mammary gland, it is present in both genders, male and female, well developed in females as compared to male, that is why it's more prominent. It is technically a modified sweat gland present in subcutaneous tissue here, and it is a necessary organ of reproduction, not technically helping in reproduction in the direct manner, but as the newborn is born and then to feed them, so that's why it is called accessory organ of reproduction. So due to this again overlap, in some books you may read its histology in the skin, in the integumentary system. In some books you will read it with the organs of the reproductive tract. This gland, it's present over the chest region, and where it lies, that is called its base. As you can see vertically, it is lying roughly at the level of rib number 2. Here rib is not shown, but this angle of Louis will help you identify it, and below it will go all the way till rib number 6 roughly, and horizontally it will come up till the lateral border of the sternum, and laterally it will go all the way till middle of axilla, that is mid axillary line, more prominently shown right here. So here is the second rib. It is dissected out, but its some parts will be present till here, and is the second, third, fourth, fifth, sixth, and it's present till here, and there may be some distance and it may go up to mid axillary line, but again there is a little variation. However, the base, it's fairly constant as compared to the superficial structures. Even with a person with more pendulous or more fatty tissue may have the base that is similar to that of counterpart lean person. Deep relations, when talking about the skin and when talking about the layers of the tissue, there is a skin on the top, then there is superficial fascia, deep fascia that is covering the muscles, and then comes the muscles and rib cage below it. So it is present in the subcutaneous tissue, the superficial fat containing tissue. That tissue also contains the sweat glands, and below it the deep fascia is the pectoralis fascia. As you can see, here is the pectoralis muscle, this one, this is the pectoralis major muscle. So it below the superficial fascia there lies the fascia covering the pec major, pectoralis fascia, and beneath it there is in front of pectoralis fascia, behind the mammary gland, there is part of loose areolar connective tissue that is called the retromammary space. This gland, this breast tissue, it's lying on top of the following muscles. There is pectoralis major muscle, as you can see right here. It lies right here. Beneath it, pec minor muscle can be regarded as a relation, but it is directly not in contact. Then there is the slip of these muscles. So these are serratus anterior muscles, this one. Then there are these muscles, these slips. So these are external oblique muscles. And then there is this fascia going here. This is the anterior rectus sheath. We have seen them in the lectures on the gross anatomy of abdomen, but you have seen serratus anterior, pec major and minor in the lecture on muscles of pectoral girdle. Here is the picture from BD Churacea. As you can see, here is the breast tissue in the superficial fascia beneath it. Here in the purple color, this is the retromammary space, the loose connective tissue. Beneath it in the green, there is a condensed form of fascia covering the muscle, that is the deep fascia, pectoralis fascia, covering the pec major muscle right here. So talking about retromammary space, and this is a loose tissue, so it allows the tissue to move relatively freely above the rib cage below, or relatively above the pec major below. So even in the males, this is very prominent, this free movement. And when if talking about the free movement, you can compare it with the front of your palm, try moving the skin and then try moving the skin. So you can see like breast tissue is like this, it is freely mobile above the pectoral fascia, and this piece of information becomes very important when in the clinical examination you find it not so freely mobile over the pec major. So you think that there is some cancer or some tissue or some pathology that is connecting the breast tissue with the pec major or pectoralis fascia below. And the breast tissue is expanded laterally to the going to the axilla. So this extension is called the axillary tail of Smens. This is the part of the upper outer quadrant. It usually lies in the superficial fascia, but sometimes it penetrates the deep fascia to reach the axillary floor. And this penetration in the deep fascia, this space that is created, this is called foramen of Lange. So this is a picture from Grant's Atlas showing the same item. There is the breast tissue, the skin and superficial fascia has been removed elsewhere along with the deep fascia, by the way. And here is the extension going into the axilla. So this is the axillary tail of Spence. To simplifying the study of the breast, or to be able to better localize the breast tissue, it is divided into 4 quadrants through a vertical line passing through the nipple and through a horizontal line passing through the nipple. There are 4 pieces that are created or called the quadrants: supromedial, inframedial, infralateral and supralateral quadrants, and they help in describing some pathology or some location very easily. So let's say we can see I'm talking about the mole that is present in the supralateral quadrant 5 centimeter from the nipple. So that's how you can localize it, and also it has an importance regarding the incidence of various diseases. For example, in this, the percentages show the incidence of carcinoma breast. So upper lateral quadrant is the one that has chance of 60% chance of carrying breast cancer as compared to total of breast, or in other words, you can see 60% of carcinoma breast are detected here in the upper lateral quadrant. Now let us talk about the structure of this tissue. Skin. When talking about the skin, so breast tissue is visible as a prominence in the front of the chest, more so in the females as compared to the males, and even in the females this shape can vary very extensively depending upon the age, ethnicity, nutritional status, and the type and the point on the reproductive cycle where she is, if she is nulliparous or she is in pregnancy and so on. So this is the skin, and apart from being pendulous or expanded, this is more or less same as the skin otherwise. At the apex there is this protuberance, this is the nipple, and this contains various longitudinal and circular muscles that allows the changes in shape, and surrounding it this dark area of skin, this is called areola. In the pre-puberty females and in males, this is very constantly lying at the surface marking of fourth intercostal space, but as this tissue grows, this surface landmark does not hold true very consistently as the tissue grows in size. If you look at it closer, there is the nipple, there is the areola, and you can see these small tags, these small elevations. These are tubercles of Montgomery, and these are basically created by the sebaceous glands that are present beneath them. And sebaceous glands are type of gland that secrete oily secretions, and when they secrete that, they become very helpful in lactating mothers whose skin is prone to crack and bleed and get infected due to the constant exposure to the saliva. So this oily secretion helps keep it soft and healthy. When talking about the internal structure of the gland, like any other gland on the body, it can be divided into two parts, the stroma and the parenchyma. The stroma is the supporting structure. By supporting, I mean this yellow color fat and this white color fibrous tissue, all of the things that keeps the gland in place. Like in other glands, there are capsule and there are septa present. Similarly, there are septa, these are white color fibrous septa are present, and in between them empty spaces are filled with fat. So all of this is considered a stroma, and the rest of the actual secreting component, this is the parenchyma. It's the functional part, starting from all the way from glands to the ending part. I will go through the gland, then I will come back to the nipple on the top to show of which what are the openings and other things. So this stroma that is supporting the breast tissue, it's partially fatty and partly fibrous. The fatty part is shown in the yellow color here, and this is what makes up the breast, most of the area of the breast in young females who have not yet lactated, who have not yet given birth, and that gives a very uniform appearance of the breast to the adult females. And then there is this white structure. This is suspensory ligaments of Cooper. This is the condensation of deep fascia that connects the pectoralis fascia below. Here is the pectoralis muscle covered by pectoralis fascia to the skin in front, and this interconnecting network, this help divide the glands into different parts. As you can see, this part is different from here, and this support the gland. This gives a classical perky appearance of the breast in young female, but as the females get pregnant and they start lactating, they stretch out, and when those glandular part and this secretory part, then parenchyma part, replace the fat, and the ligaments that stretch out, and when they stop lactating, the glands regress back to size, and that's why the gland goes back to the pendular appearance. And the space behind the gland, between the pectoralis fascia and the gland, pectoralis fascia behind and gland in front, that is called the retromammary space. That is the loose areolar tissue that gives the mobility to the gland. Here is a picture from the other perspective too. So here are the pectoralis major covered by pectoralis fascia. In front of it, this fairly constant extension of this fat, this is the retromammary space, and here in the white color, these are the suspensory ligaments of Cooper. As you can see, they are running from the posterior aspect all the way till the skin and dividing the gland into different parts. And here you have to understand its connection with the skin. If there is any pathology, let's say if a person gets hit here, there is a bleeding, there is a trauma here, and that place get bruised and then contracts. If it contracts, it will pull the skin towards it, and it will cause a skin dimpling, and that occurs in the carcinomas too. When the carcinoma involves suspensory ligaments of Cooper, it alters the regular appearance of breast. And similarly, this becomes very important when talking about the lymphatic drainage. when there is a lymphatic drainage in all the tissues of the body, they are constantly being drained. But if due to cancer or some other issues the lymphatic drainage is blocked, then the fluid tends to start accumulating and the breast starts to swell. And when the breast starts to swell, the breast tends to increase in size, but these non extensible or non flexible connections, these does not extend. So rather than the breast expand, all the points of attachment of ligament of Cooper, they get it buried deep inside. So that gives the breast pitted appearance. I'll show you by the end of this lecture. So here's a picture from Grant Atlas showing the majorly focus on the stroma and focusing on suspensory ligaments of Cooper as going by removing the tissue and the fat between them. Here's again the picture from the BD Churacea focusing on pectoralis fascia and the connections of ligament of Cooper between pectoralis fascia all the way to the skin. As you can see, this ligament of Cooper is majorly spread out uniformly on the skin surrounding the breast and not so much as the nipple. So I am focusing on this point because any dip, any pull, any retraction in the skin may suggest you that ligament of Cooper was involved that caused the pull. Any pull in the nipple will show a secretory component, the parenchyma was involved that lead to the retraction of the nipple. Let us talk about the parenchyma. Parenchyma is the actual secretory component. It started from these swellings, these rounded alveoli, acini, they actually produce the milk or secretion, and they start going through the ductules and they join together and together to form larger and larger ducts, and this duct ultimately join together to form a lactiferous duct. There is a dilatation in the lactiferous duct just before the nipple. This is called lactiferous sinus, and after that there is lactiferous ducts going from the sinus to the tip of the nipple. So this whole structure, all the thing, all the acini and ductules and the things that are draining into a single lactiferous duct, this whole structure makes up one lobe of the parenchyma. So breast consists of 15 to 20 such lobes, and these smaller groups are called lobules, and from there there's a ductules, and then there's lactiferous sinus. The milk constantly is being secreted here and gets lodged here, and when the child has to feed, and due to the pressure that you have to understand that it is not due to suckling. Basically, when through with the help of lips the child puts a pressure from the sides, basically from the sides the pressure is created, and this compresses the lactiferous sinuses, and the milk that has been accumulated here, it is pushed outside. So this is a little 3D rendering and showing the lactiferous sinuses and ducts behind it and all the acini together entering into it. This is called lactiferous, this is called a lobe or lobule. And here this picture is a little misleading because all of these does not open into the surface of the skin through one opening. Actually these open through many independent openings. So these openings are all, so the tip of the nipple does not have a single opening, it has 15 to 20 different openings for each of the different lobes, each of the different lactiferous sinuses. So the lobes, we talked about these are 15 to 20 in numbers and make up of different lobules, and they end empty via ductules into the lactiferous ducts, get together in lactiferous sinuses, and each lactiferous duct open separately onto the nipple. So that was we discussed about. Now let us talk about the neurovasculature. Its arterial supply, its venous drainage, its lymphatic drainage, and its nerve supply. Arterial supply, again, if you have gone through the arteries that are present in axilla, it is majorly being supplied by the branches of axillary artery on the lateral aspect and subclavian artery on the medial aspect. So this is the brachiocephalic artery from the heart, giving the common carotid artery to the head and neck and subclavian artery to the upper limb. This same artery, when it crosses the first rib, so here its name is subclavian artery, and as it crosses the first rib, its name become axillary artery. So one, you don't need to memorize the branches of subclavian artery right now, but one branch of the axillary artery, that is internal thoracic artery, that runs on the inner aspect of the ribs, and on parallel to the lateral margin of sternum. So this is called internal thoracic artery or internal mammary artery, sometimes the parasternal artery. So this internal thoracic artery, and throughout its length it gives branches anteriorly going through the spaces between the cartilages, intercostal spaces. These are called perforating branches. So these perforating branches, especially from the second and third and including fourth and fifth space, so these are the ones that are going to supply the breast from the medial aspect. Then comes the axillary artery. There again 6 branches, not talking about those from the superior aspect. One artery that is not shown here, that is the superior thoracic artery or highest thoracic artery from the first part of axillary artery here. And then there is pectoral branch of thoracoacromial artery. This is the thoracoacromial artery. This is one of the 4 branches of it. And then there is a lateral thoracic artery, majorly supplying on from the lateral aspect. Then comes these branches, these ones. These are the lateral cutaneous branches of the posterior intercostal arteries. Let me show you them on more detail. The branches that I show here is the labeling for if you want to pause the video here and go through them. So I have discussed in detail in the thorax lectures. You can visit them in our website or our YouTube channel. But here I will go to a quick reminder that the rib cage consists of ribs and the spaces between them, the intercostal spaces. The intercostal spaces contains the intercostal arteries, majorly coming from the aorta behind and internal thoracic artery in front. The arteries going from the aorta in the back, they go and run between the muscle layers and all the way go to the sternum. And here, before going that, they give a branch in the lateral aspect that goes to the skin, and its posterior division goes to the back and anterior division goes to the front. Let me show you a more easier picture here. So aorta gives a branch, some branches goes to the back, and the one that goes to the front, these are the intercostal artery. And here it gives a lateral cutaneous branch, and it have a posterior division and anterior division supplying the skin on these aspects. And in front you saw the internal thoracic artery with its perforating branch. So the breast tissue was not only supplied by this perforating branches of internal thoracic artery, but also by the lateral cutaneous branches of the intercostal arteries. To be more specific, anterior division of lateral cutaneous branch of the posterior intercostal artery. And now as you will go into the thorax, these arteries will become a little more complex because not all of them arise from aorta in back or internal thoracic in front, but that gives a pretty much idea for what you need to know for this particular topic. So here's the picture from Netter's Atlas showing all these things, showing the internal thoracic artery, their anterior perforating branches supplying from the medial aspect. Again, superior thoracic artery not shown, it will be somewhere here, supplying it from the front. Then there is pectoral branch of thoracoacromial artery. This is a lateral thoracic artery supplying it from the side. And here, as you can see, from here, here, and here, you can see anterior divisions of lateral cutaneous branches of posterior intercostal arteries. I know it's a little mouthful, but because if you know it, it's not that much difficult. Then there comes the veins, and the major veins are almost the same. On the medial aspect, draining into the anterior perforating branches of internal mammary artery. On the superior aspect, majorly going to the superior thoracic. On the lateral aspect and superior aspect, the superior thoracic artery and pectoral branch of thoracoacromial. On the lateral aspect, going into the lateral thoracic vein, and there is the anterior division of lateral cutaneous branches of posterior intercostal veins. So these are all the same drainages, but when talking about the plexus of veins that is present just beneath the skin, that is called subcutaneous plexus, it's a little different and a little muddied basically, because just beneath the skin there is a whole network of interconnections and there is a web of veins that is present, and this web of veins drain pretty much radially everywhere. So in thorax, majorly it goes to here lateral thoracic, and it goes there. It has the connection on the opposite side from the medial aspect, and it will have connections with those of the abdomen veins. So you have to keep that in mind. You have to keep an open mind regarding the superficial veins. Yes, major of them will go to the axilla, to the lateral thoracic vein, and from the medial aspect the major will go to the internal thoracic vein too, but you will have to keep an open mind because the superficial venous system is not that much demarcated. Then let us talk about the nerve supply. The nerve supply is through intercostal nerves. The intercostal nerves follow the exact same path as the intercostal arteries, coming from the back, running between the ribs, and giving lateral cutaneous branch and anterior cutaneous branch. So it is supplied by both this lateral cutaneous branch, and not very much clearly shown here. This anterior cutaneous branch arises here and comes to this aspect. So it is supplied by both lateral cutaneous branches and anterior perforating cutaneous branches of the intercostal nerves. And keep in mind that this nerve supply, it's only for the cutaneous, it's only for the sensory aspect. These anterior cutaneous and lateral cutaneous branches supply the skin of the breast, and some areas are more sensitive to the others, as we can discuss about nipple. But this nerve supply does not directly relate to the milk production. There is no nerve pathway that says okay, produce milk now. But yes, indirectly, when the baby tries to when the baby is latched onto the mother, this sensory supply from the same nerves, they gives a signal to the brain, and then through the hypothalamus those secretions are given, those hormones are given, that prolactin, that ultimately leads to the letting down of milk and production of the milk by prolactin and letting down by oxytocin. Okay, by now you might have discussed the concept of dermatome, or of the area of the skin that is supplied by a single segment of spinal nerve, or the area of the skin that is supplied by a single spinal nerve, that is the dermatome. There are different dermatomes from the head. We will start from C2 all the way to C5 till the manubrio-sternal angle right here. There's, uh, then there is for each dermatome T1, T2, T3. You have to remember that the area of the breast is supplied by T2 to T6 roughly, but the thing to remember for exam point of view is that the area of the nipple, this is supplied by the dermatome T4. And here comes an important part. In a prepubertal female and in a males, when their breast tissue is not well developed, the surface anatomy, the nipple lies over the fourth intercostal space. But in a female will have much developed breast, especially those who have lactated, the surface landmark may not correlate. They may be much lower down as compared to the fourth intercostal space, but despite that, the nerve supply remains the same, and despite the size changes or shape changes in the breast. And this becomes important when we are trying to figure out where an injury is. For example, a person comes to you with an injury of thorax, you try to figure out the different dermatome levels at which the sensation is present and sensation is lost. So we have different landmarks, like at the angle of Louis there is T2, at the nipple there is T5, T4, at the xiphoesternal angle T6, T7, at umbilicus T10. So it is one of the major points that you have to memorize. Then comes the lymphatic drainage. There I will going through a number of pictures. I hope so these are more helpful than confusing, but let me go through. So two lymph nodes that you must memorize. On the lateral aspect, it is majorly drained by these nodes, and then running around the internal thoracic artery. These are internal memory nodes, and on the lateral aspect, the lymphatics are going to the axillary nodes, particularly anterior group of axillary nodes. Right now, at this point, some of you might not have studied the axilla in detail. So let me go into discuss briefly the axillary nodes. Axilla is the space that is present between the rib cage here and the arm there. This empty space in the armpit, this is the axilla. So it's a pyramid shaped structure. It has base of the pyramid. This is the skin that is present, and if you go up, there is the apex of the pyramid. So the three corners of the base of the pyramids contain three group of nodes. The anteriorly, there is anterior group of axillary nodes, otherwise known as pectoral group. If you have gone through the lecture on the muscle, you will see here is the pectoralis muscle present. Posteriorly, there is posterior group of axillary nodes or subscapular muscle near the subscapular muscle, and lateral aspect because it's just near the humerus. These are called humeral nodes. So pectoral group majorly drains the lymphatics from the front of the chest, and here our discussion, it is very relevant because it drains the much of the chest too, as it's part of the interior of the thorax. Subscapular, the posterior group majorly drains the back of the thorax, when we were talking about the lymphatic drainage from the back, we will discuss it. And the lateral group or humeral group, this majorly drains the upper limb. As it comes, the deep lymphatics of the upper limb are drained here. The lymphatics from all of these goes to the lymphatic nodes present in the middle of the parenchyma, the central nodes. From the central nodes, they go into the nodes near the apex, the apical nodes, and from there they go to the supraclavicular nodes above the clavicle, and from there they go to the right lymphatic duct or thoracic duct on the left. So this is pathway will be shown in most of the pictures. You will see here is the internal mammary nodes. There is the axillary, anterior, lateral, posterior axillary nodes, also called pectoral, humeral, and subscapular nodes. They drain into axillary nodes and they drain into apical nodes and they drain into supraclavicular node that drain further. Let me go through again. So here is a picture from Grant's Atlas, I think. The breast, the part of the breast, I will talking about immediately talking about two areas. The most of the medial aspect, it majorly goes to this node, internal thoracic node. Most of the lateral aspect, it goes to this node, pectoral nodes. Roughly 75% of the lymphatics are drained here, roughly 20% of the lymphatics drained here, and then the rest is, well, let's follow them. For first, pectoral nodes that goes to the central and apical. Again, this is not that much in black and white. They go jump directly to apical nodes and then to subclavian trunk, supraclavicular nodes, and then all the way. There are some other drainage sites too. uh, Before going into that, this area, the lymphatic plexus just below the areola, it is very well developed. This is called subareolar plexus, the plexus of lymphatics just below the areola. It does not discern the medial and lateral aspect. On the medial aspect of alveolar 2 and the lateral aspect of alveolar 2, the lymphatics go to the lateral aspect all the way to the pectoral nodes. So even if you know these 3 points, you will be set for the examination. So the bulk of the tissue on the medial aspect goes to internal thoracic nodes. The bulk of the tissue, deep tissue on the lateral aspect goes to the pectoral nodes, and the skin below the alveolar, the skin below the nipple, regardless of its medial and lateral aspect, goes to the lateral pectoral, anterior nodes, anterior axillary nodes or pectoral nodes. Then there are other nodes too. The lymphatics may cross the midline and cross to the internal thoracic nodes on the opposite side. They may go down and go to the lymphatics drainage the various parts of the abdominal cavity, like to the rectus sheath or subperitoneal plexus. They may go to the axilla and they may drain into some other group of node other than pectoral node, like subscapular nodes or nodes. And you talked about the artery, the lateral cutaneous branches supplying the artery on the lateral aspect of breast. They may travel along those arteries and go to the back of the thorax and drain into the posterior intercostal nodes, or they may go up and directly they may go into the apical nodes, and there is another node present between the pec major and pec minor, the interpectoral node. They may go through them to those. So there are other nodes that are present too. Now I have tried to progressively go into the more difficult pictures. So I will discuss the lymphatics again. So axillary lymphatics, it goes to the medial aspect, goes to the internal thoracic and internal mammary nodes, and these are also called parasternal nodes. They join together to form a duct that is called brachiocephalic duct, and this go into the right lymphatic duct on the right side and thoracic duct on the left side. On the lateral aspect goes to this, majorly goes to the pectoral nodes. The anterior pectoral node may go to the subscapular, may go to the humeral nodes too, but majorly goes to the subpectoral nodes. They may directly go to the central nodes too. From there they go to the apical nodes, may get directly from the interpectoral nodes to apical node here, and then from there they go to the supraclavicular node, and there together they form the subclavian trunk, and through that subclavian trunk ultimately drains the lymphatics of the upper limb to the right thoracic duct or right lymphatic duct or right thoracic duct. It usually drains into the angle between the internal jugular vein and the subclavian vein. And then there are again variations, not going into those details. So here is a summary. Major drainage 75% is to the axillary nodes, chiefly the anterior or pectoral nodes. Then on the medial aspect there is internal mammary or parasternal. Then there comes the other ones, the supraclavicular direct drainage, the infraclavicular direct drainage, the interpectoral, the posterior intercostal, the anteabdominal wall, and the opposite breast. These becomes very important when the major pathways are blocked. For example, a female has metastatic cancer and the cancer has been traveling through these pathways and have ultimately blocked these pathways, anterior nodes or parasternal pathway. Then these alternate pathways become very important. Then you will have to look along those pathways too for the spread of the cancer. Here is a picture from Netter's Atlas showing internal mammary, interpectoral, anterior or pectoral nodes or posterior subscapular nodes, lateral or humeral nodes, central, apical, and then there is supraclavicular nodes. The study of the lymphatics of the breast is very important because through those the cancer spreads. So depending upon the different nodes, different pathways that are shared, the cancer may spread through the lymphatics to the opposite breast. The cancer may spread through the posterior intercostal nodes to the ribs and vertebra. It may go through the abdominal wall to the liver. It may go down to the ovary and even lower limb. And one important route of spread is through venous drainage. Through venous drainage, it goes back and goes to the back veins near the back of the body, and it may get deposited into the vertebral column. Okay, so we have now discussed the gross anatomy of breast, and before talking about the pathologies, I will briefly discuss the development of breast that will help us discuss the pathologies a little easier. The breast in males, as in other mammals, develops from this line. This is the mammary ridge or milk line. So if the breast is developed, it is to be developed in this line. In humans, usually there is one place in the thoracic region where the breast is developed, but if you can see in the other animals like in cattle or even in canines like dogs and other animals, you can see there is a line of mammary glands, the nipples or mammary glands in line. So this line is the mammary ridge. This line is very important to study in humans because if there is an extra breast tissue that is developed, it will develop only on this line. So if the extra nipple may be present here or here or here, it usually does not develop other way like here. So it helps to differentiate that like this structure that is extra present here, it is a breast tissue or not. So it develops from the skin, the ectoderm of the skin, which goes inside and divides until it makes the goes inside, then it is cannulated and form the different ducts and lobules. And before the puberty, the branching has taken place, and it does not have any alveoli in the end. In the menstrual cycle, they alveoli they develop a little more or less different parts of the menstrual cycle, but they usually develop more during the first pregnancy where alveoli becomes cannulated on the secretion present in them, and lactating female has very prominent milk secretion among them, and this remains till the time the female is lactating, and when the child grows up and is weaned off, then the breast tissue regresses in size, and it may goes again to this size when she's pregnant next time or lactating the other time. And even this is regressed to this part, the secretory component is reduced when female gets older and gets in the menopause, because most of the support is going through the hormones. So that is why its breast changes shape as go from childhood to puberty. So here is again the same thing shown in the different picture, not dwelling on it right now. Next, let's talk about the abnormalities. When there is nipple retraction and when there is any pathology in the breast, maybe a scar tissue, maybe an inflammation, maybe a trauma, and more um, when it's a little more worrying, for that is the tumor. It involves the ducts. Then the ducts, when the tumor, this scar tissue when contracts, it pulls the ducts, and as the ducts are going to the tip of the nipple may be pulled inward. So this is the nipple retraction. As you can see, rather than a protuberance, you can see a dip. Then there is a possibility that there will be more than one breast. So this is called polythelia. More than one nipples, to be more specific, this is called polythelia. Athelia, in the absence of breast, as you can see from here to here, this part is not well developed. Then here is the amestia. This is athelia, absence of nipple. Breast tissue is absent, that is amestia. Breast tissue is duplicated, polymestia. Nipple is duplicated, polythelia. Breast tissue is duplicated, that is polymestia. And in the males, if due to hormonal balances or some other cause the male breast tissue is developed, that is called gynecomastia. Then there is skin dimpling, and skin dimpling, it's caused when due to any pathology like hair, any cancer. When it contracts, it may pull on the ligament of Cooper and suspensory ligaments, and it pull on the skin. So this is called skin dimpling. Here is the proto-orange appearance, the orange peel skin. When the breast has blocked lymphatics due to any pathology, the breast tends to swell, but the points of attachments of the ligaments of Cooper, they remains there. So it expands, and as it swells becomes a little red, but the points of attachment of ligament Cooper, they are pulled in, so this gives a pitted appearance. When the lactiferous ducts are involved, there is a nipple retraction, it can be pulled in, and any pathology may lead to changes in the normal rounded contour of the breast that is normally seen. So any change in the breast appearance, in the nipple, in the contour, in the retraction should be examined very quickly for any pathology that can be amended. To see inside the breast, we do X-ray, and the X-ray of the X-ray radiograph. This radiograph of the breast is called mammography. You place it between sheets, flatten it, and then take a picture. You can take it from above, you can take it from the side, depending upon what you want to see. And ultrasonographically, breast can be visualized too. So that's it. I hope so this has been helpful for you. If you have any questions, suggestion, and feedback, please let me know. I will be looking forward to your feedbacks in the comment section. See you in the next lecture. Till then, Allah Hafiz.